I would like to introduce Dr. Monica McLemore. She is a tenured associate professor in the Family Health Care Nursing Department and affiliate scientist with advancing new standards in reproductive health at the University of California, San Francisco. She currently holds the Thelma Shobe Endowed Chair, and in 2019, she retired from active clinical practice after a 28-year clinical nursing career. She continues, however, to provide COVID and flu vaccines. Her program of research is focused on understanding reproductive health and justice. To date, she has 87 peer-reviewed articles, op-eds, and commentaries, and her research has been cited in 5 amicus briefs to the Supreme Court of the United States, 3 National Academy of Science, Engineering, and Medicine reports, and a data visualization project in the 2019 Future of Medicine edition of Scientific America. So please welcome Dr. Monica McLemore. And I will stop sharing my screen. Yay.
Well, first of all, thank you so much, Dr. Oxford, for having me. I have been a fan of the Barnard Center and Infant Mental Health for a while, and it's nice to see so many people on this call that I actually know. And, you know, shout out to Paula, who I actually got a chance to meet prior to the pandemic in Louisiana and have some great discussions with her. So before I start, I probably should update my introduction and my bio since, you know, it is now official. I got a call from Dr. Teresa Ward yesterday, late in the evening, that my packet to join the faculty at the University of Washington as a full professor of nursing and public health was unanimously approved yesterday. So I am super excited to be joining the UW faculty. I will be returning to the adjunct series at the University of California, San Francisco, effective June 30th. With that, I want to start off with a couple of things. First of all, happy Black Maternal Health Awareness Week. The week started yesterday. It is a 5-year anniversary. Actually, we had an early start to Black maternal health because the Biden and Harris administration put out their second presidential proclamation declaring April 11th through April 17th Black Maternal Health Awareness Week late on Friday. And people probably missed that, especially those of you who were with me at the Western Institute of Nursing meeting in Portland, Oregon. But we are so thrilled to be partnering again with the Century Foundation, the Black Mamas Matter Alliance, the White House, the Century Foundation, National Birth Equity Collaborative, and a whole lot of other people who made Black Maternal Health Week, which is always the week before Easter, a week of awareness and consciousness raising, of highlighting some very important issues. And keep your eye on all social media channels tomorrow, because there's going to be some exciting announcements coming from the White House and the Vice President's office specific to Black maternal health and the mominess. So that's it. I want to talk to you about a couple of different things today. I'm not wedded to getting through my slide set. I probably have about 38. I will share them with you. They're mostly pictures. I'm going to tell you some stories and you'll have them available to you. But I really want us to think about, I get really tired of the doom and gloom lectures and, oh, Roe is going to fall, and oh, what do we do? The hand wringing, the weirdness. I just can't even be bothered, because a different future is possible and we can actually make it happen. And I want to direct us to the path as to how we do that. So with that, I'm going to start with a couple of caveats. If I can figure out how to make my computer work. Here we go. Okay. We want to honor the work that's been done in reproductive health rights and justice. And my other namesake, Monica Ray Simpson, outlined this clearly in an op-ed in the New York Times yesterday about how, you know, reproductive health and Roe was the floor, but reproductive justice is the ceiling, right? And I want to really get us using the language and the ideas and the actions behind reproductive justice. That's why I want to talk about how do we operationalize it, and to really teach this audience and many others that, like, we can make this all different. We actually, it's within our capacity to do so. And there are steps that we need to take in order to make it happen. But if we all work together, we actually can make this all different. Before I begin, it would be ridiculous not to shout out the founding mothers of reproductive justice. So for those people who don't know the history of RJ, they wanted to really bring together reproductive health and reproductive rights with social justice. That's where you get reproductive justice from. These are the founding members who really developed reproductive justice in response to a meeting that was happening in 1994 in Chicago. And I'm happy to say that more than half these people are still alive. And Dr. Tony Bond happens to be a postdoc who works with me. So if you don't know the work of these incredible women, I highly suggest that you research these names, that you read their work. I mean, Dr. Loretta Ross is still alive and is prolific in terms of her writings and the work that she's doing, as is, Evelyn Field and Elizabeth Terry. So if you are not familiar with these names, I highly recommend that you start to read their work and you really think about their ideas and their contributions to the broader field. I always start with some definitions because I think it's really important that we all get on the same page. Reproductive rights are the legal protections that allow us as citizens to be able to operationalize our lives, right? Reproductive health is health services provision. I'm a nurse, right? I can probably put your IV in from like 15 miles away with my eyes closed upside down. That's health services provision. We are one-on-one in a room talking through what your health concerns are. But reproductive justice is really different. And it is inclusive of, but even more expansive than reproductive health or reproductive rights. And I'm going to give you a couple of different definitions. But there's some tenets of reproductive justice that we need to go over that I think are really, really important, that distinguishes RJ, which is what we like to call it, from reproductive health and reproductive rights. This is the definition that I like to use. I'm not going to read it, but I will point to some highlights that I think are really important. Reproductive justice is grounded in human rights, right? And human rights are super important as a frame because human rights are not subject to who's in office. They can't be voted on. They are basic guarantees that every sentient being on this planet should be afforded to, right? I mean, so there's some just fundamental things that we believe that just by nature of being human on Earth, that you should have rights to. And in my view, one of those things is bodily autonomy. So currently, we have bodily autonomy, theoretically, in life and death, right? If you died tomorrow, nobody could go dig up your remains without your consent. It's one of the reasons why we have organ donation cards. It's one of the reasons bodily autonomy is an idea that we believe, grounded in human rights, that you should be able to do with your body in life and death. You should have some say over that. And so reproductive justice, by grounding it in human rights, it reaffirms this notion of bodily autonomy. But simply put, this is the definition that Sister Song, the Women Reproductive Justice Collective, that Monica Ray Simpson, who I previously named as having an op-ed in the New York Times yesterday, she runs that organization. I add on a fourth tenet that came from a couple of different people's conceptualization. I think at some point we need to have a conversation about disassociating sex from reproduction and looking at healthy sexuality and pleasure and consent as parts of having a whole human life. So speaking of consent, I did not give you my affirmative consent, but I will go ahead and do that now. You have my affirmative consent to screenshot my slides. I'm going to share them with you after my talk. You have my affirmative consent to tweet, to Instagram Live, to put on Facebook. You have my consent to do those things. And I think if we get to a point where we can normalize affirmative consent, then we can demystify what is acceptable and what is not acceptable behavior when we are in crowds, when we are on social media, when we are interacting on the internet. So I'm trying to model that behavior. The other piece that I did not share, and that is that I prefer to use the pronouns she, her, and her. So let me get into some key concepts and some considerations, because in order to understand reproductive justice, you have to have a certain shared understanding and background and foundation of how we got where we are. So for me, a lot of people have been talking over the last 20 years about the social determinants of health. And I'm really glad that, To Err is Human and, looking at health disparities, unequal treatment, all the IOM reports that have come out But the truth of the matter is social determinants of health do not fall out of the sky. They aren't plucked from thin air. They are created. And they can be positive social determinants of health, or they can be negative social determinants of health, right? This idea that transportation is a neutral thing. Actually, there were policy decisions that made transportation a thing in the United States. They still are, right? Whether you're talking about high-speed rail or whether we talk about masks on planes, right? These things don't fall out of the sky. Social determinants of health are born through power and wealth imbalance. And power and wealth imbalance come from three things. They come from class oppression, racism, and patriarchy, right? We can make different decisions if we really wanted to around safe and affordable housing. We can make different decisions around the availability of food. We can make different decisions around paying our citizens a living wage or basic minimum income. Like, these are policy decisions. So when we start to look at the downstream factors, this idea that there are differences or disparities between groups of individuals, both in well-being, but also in illness, we shouldn't be confused about why that is, because there are inequitable distribution of resources that lead to wellness, or there's over distribution of those factors that lead to poor health. Let me say it again, right? Distributions in populations are generated because of policy decisions, right? I can never forget the time that I had the moment when I recognized that poverty was a policy decision. And then I took it a step further and said to myself, I don't understand how we're ever going to resolve the negative social determinants of health if we don't have a robust social safety net. Right? It is really hard. Of course, we're seeing all these things show up on the poor health and medical side and healthcare side because we don't have a robust social safety net. I mean, we are a species that are not immortal, right? So as long as that's true, then how do we get people to have a dignified life regardless of what the risk factors are for health-related conditions? Well, that's the work of a strong social safety net. We call it Health and Human Services for a reason, right? And so when we see poor health, I am now geared towards thinking about, okay, well, where are the social structures that we could have put in place to actually ensure improved or superior outcomes? So an easier way to say this is this: the social determinants of health are not plucked out of thin air. They are a result of policy decisions, and health disparities arise from structural racism. And so when we continue to see health inequities, they persist because of structural racism. And so we dismantle structural racism, then one could argue that we could see health inequities resolved. This is coming out in a paper in the Journal of Perinatal and Neonatal Nursing. A lot of people have asked me about this as a framework that I use to think about different conversations when we want to allocate resources. And when I use the word resources, I mean space, money, human, and time resources. I don't just mean money, because in some communities, the human and the time and the space resources are actually more important than money. And so when we reduce conversations about resources just to money, money is serving as a proxy for the humans and the space and the time that's necessary, but we need to name all four of those, right? And the reason I want to present this framework to you is because we can't operationalize reproductive justice if we're all not having the same conversation. And a lot of times we're not all having the same conversation. And so I'm going to give you some examples of what I mean by that. But first, some definitions from Merriam-Webster. So if you got to take care of yourself, if you need to, deal with kids or go to the bathroom or whatever, bio break, do that, because I'm just going to show you some definitions from Merriam-Webster that you can look up yourself. But I think it's important that I highlight how I'm using these words. There are three definitions in Merriam-Webster specific to retrofit. It's a verb. We want to adapt to a new purpose or a new need. One of the most important points that I can make is that in retrofitting, the inherent structure remains exactly the way that it is. It doesn't change. You are retrofitting that structure. So when we have a discussion, sometimes people are retrofitting things. That means the inherent assumption that we all have to appreciate is the structure as it exists is not going to change. Okay. So when we talk about retrofitting academia and trying to diversify our workforce and or our faculty, that means the fundamental structure of academia is going to stay the same. Okay, that's an important distinction then when we're talking about reform. So there are 4 definitions in Merriam-Webster when we think about reformation or to reform as a verb. I like the first one because the first one is a unicorn in healthcare. The first one actually has the words, we can remove something, right? So we can change the inherent structure. We can take things off that no longer work or that are dated or that perhaps maybe could be allocated to somebody else. So for me, I like the difference in my mind between retrofit and reform is retrofit, the inherent structure is going to stay the same. Reform, you can actually change the source material such that we can, get on the train to building something new. A lot of us like to spend time here. Reimagining. We want to think of something new. We want to conceptualize. We want to recreate something. We spend a lot of time here. Here's the problem with reimagine. It's always aspirational. Right? There's no accountability in reimagine. We can sit and daydream all day, right? But there's no actions that are associated with that reimagination. But here's the cool thing about reimagine, retrofit, and reform. They're all necessary at the same time. They're not linear. It's a circle. And we need people cycling through all 3 of these ways of thinking at the same time. The problem is we all can't be in the same domain at the same time. So if everybody is in a reimagined space, but you don't have any retrofitters, then we're going to be confused about the strategies that are necessary to take care of the people in the now. So if everybody's on team reform and we're trying to blow up the inherent structure, but the structure actually, some structure needs to remain in order for us to be functional, then we're not having the same conversation. So let me apply this. Why do we care about this? Well, because if you think about it, a retrofit could be the past, which is reproductive health services and health services provision. Reform could be the present, where we're looking at reproductive rights and the battles that are going on to protect things like contraception and abortion and access to trans health care and a whole variety of other things. But then we can think about reproductive justice as a reimagination. It's the future. And we need all 3 of these things right now. So how does reproductive justice, in the way that I defined it, the right to be able to, make family and kin and birth and have all the dignified supports that one needs in order to be able to do that, the right to, prevent or end pregnancies with all the dignified supports that one needs to be able to do that, the right to parent children in healthy environments free from violence from any individual or from the state. How does reproductive justice relate to research? Well, number one, when we think about a research agenda, you have to decide who are the key players and what's the strategies that we want to be able to use. Who gets to decide what research questions are even being asked, right? A lot of times, I think those of us who are researchers and those of us who are clinicians, we've driven the train around what research questions and what priorities are really important, but we never ask the people that we serve what's important to them. Right? Who gets to define what these theories of change are, what the funding priorities are, what the research priorities are? And who gets to determine what level of impact and what are meaningful outcomes, right? I think as we continue to think about science and informing policy, one cool thing that reproductive justice does, it forces us to ask these questions. And it really forces us to think about what are the social goods that can emerge from taking a reproductive justice approach. If we got people to understand that sexual and reproductive health, regardless of where you are on that spectrum, is an essential component to a whole healthy human life, then we would have never had arguments during the COVID-19 pandemic about whether or not access to sexual and reproductive health services was essential. I laughed when people started saying that sexual and reproductive health and abortion care provision and birth on, this was all optional. I was like, wait a minute. You are locking down an entire nation of people to be at home, to work from home. You think sexual activity is not going to happen? You don't think we still need, say for sex programs? Right? So reproductive justice allows you to trouble those kinds of discussions and conversations and connect the dots to the larger pieces of our decision making and how we think about allocation of human money, time, and space services. To the researchers in the room, and I know there are a number of you, as well as the clinicians, I mean, we have a hierarchy of knowledge producers. Let's just be very clear, right? One of my jobs as a researcher is to conduct studies that will give us findings that are new knowledge in terms of how we think about a particular phenomenon. And so to not talk about that power dynamic, and to not appreciate and understand there are some very important components that are very consistent with reproductive justice that are necessary for us to talk about. And one of those things is we need to be able to foreground or to uncover other ways of knowing. And one of the things that reproductive justice does, it assists us in doing that, because it starts from a very fundamental premise that patients and the people that we serve are experts by experience. Similar in the clinical environment, when we see patient-reported medical history as a gold standard that will help us with assessment and diagnosis and treatment, and it allows us to help turn on all our algorithms to be able to get people the care that they need. Well, even in research and even in public health, I mean, the people we serve are experts by experience, and we need to treat them as such in our hierarchies of knowledge producers. And so what does that mean, Monica? Well, that means that they need to be consulted first before we begin any research project to ensure that our outcomes and the things that we want to know are congruent with the people that we're working in partnership with, as opposed to extracting from them. Reproductive justice means that the people that we are studying and the people that we are studying with are also active participants in the conduct of the research, in the same way that we partner with them in the clinical setting. So for me, we need to start naming roles for the people that we serve, as opposed to assigning them roles. So context matters. When we're talking about operationalizing reproductive justice, I did this study with the Birthplace Lab and Dr. Saraswati Vidam and her team and a whole lot of intergenerational researchers. We found, regardless of race or ethnicity, regardless, 1 in 6 people experience mistreatment during childbirth, regardless of race and ethnicity. In my view, that's unacceptable. I've been a contiguously licensed nurse since 1993, right? I was born a preemie in 1969. Every piece of work I do is personal. This is unacceptable. And this was prior to the pandemic. So a nationally representative survey of almost 3,000 people who told us that they were being scalded or being shouted at, that they had their needs for care not met. I don't blame healthcare workers for this, because I've always said that mistreatment and clinician burnout are two sides of the same coin. And what is that coin? The coin is our workplaces are inhumane and they need to be reimagined, right? I'm not looking to blame any group. Our workplaces don't work for anybody, not us, and not for the people we serve. So let's fix them, or let's change them, right? When we did break down and looked at race or ethnicity, what we found was the top 4 types of mistreatment during childbirth by healthcare providers. They're horrifying. I mean, being shouted at or scolded, seriously, violations of physical privacy, right? I mean, this is not any one person behaving badly. This is our environment is inhumane, and we need to start simulating and teaching people and building skills as a retrofit, how to remain humane in an inhumane environment. A reform would mean that we're going to do some culture change work and some team-based training and simulation, maybe with some virtual reality, to really help to sim how do we interact with each other. A reimagine is, let's build out some new workplaces, right? The pandemic taught us we could do that. We developed what? Drive-through baby showers, non-stress testing, auxiliary maternity units in hotels. We can crowdsource some brand new ideas about how to better care, how to better partner with patients and with families and people we serve. I mean, I come from the tradition, I always say this, right, of nurse-family partnership. I come from the tradition of infant mental health. I come from the tradition of centering pregnancy and group prenatal care. That was all started by public health, nursing, and midwives, right? We can unleash the creativity of our profession and our discipline again if we decided that that's where we wanted to make our resource investment. I wrote this in 2019, and when the editors of Scientific American came to me, they wanted to title this piece, "What are the root causes of maternal morbidity and mortality?" And I said, nope, I'm not writing that piece. I said, because quite frankly, if the only living Black women that are in my piece is me and everybody else is dead, I don't want that out in the public domain, because you're missing a key fundamental message, which is the bulk of maternal morbidity and the bulk of maternal mortality in the United States is preventable. And I don't want to focus on, doom and gloom and death and dying without telling the public that there are things that we can do to prevent it. And they came back to me and they said, wow, Dr. McLemore, you're right. Right. And Valentina, who drew these beautiful graphic renderings of all the data that we summarized, this piece can be seen for free, but you got to go through Black women to do it. And that was purposive. So Scientific American, when they do data visualization projects, after 90, it's proprietary on their website for 90 days. You have to go through their website to be able to see it. And then it comes out in the print magazine as well. After 90 days, it lives in perpetuity on the internet. And so when they sent me the forever link, they said, where do you want it to go, Dr. McLemore? I said, it should live on the Black Mamas Matter Alliance resource webpage. So if you go to the Black Mamas Matter Alliance, the same people who coined Black Maternal Health Awareness Week, and you click resources, this data visualization is the first piece, and you can see it there in perpetuity for free. Also, as a nurse, I came back to them and I said, does this really need to be named the future of medicine? Can't we change the data viz in May that you do every year to the future of healthcare? And they said no, because it's been named this for 125 years since they've been in publication. I was like, darn, at least I tried, right? But those are the kinds of changes that we have the power to make. If something's going to live in perpetuity, how are you making decisions about what its focus should be? Reproductive justice would teach you that we have to provide people with strategies and solutions and not just continuing to describe a problem. That's the analytic power, or one of the analytic powers of reproductive justice, and how to operationalize it. I asked for this panel as part of the work because I really wanted people to know, yes, this is an intractable problem. Yes, it is completely horrific when a community, a family, a co-parent, a grandmama, somebody loses a pregnant person, right? But I needed folks to know, like, this is preventable. We can do something about it. We need the political courage and will, but we can do something about it. The other thing I wanted people to really understand that these are rare events. We have like an estimated 4 million births a year in the United States. I always like to contextualize that Black women are 3 to 4 times more likely to die. Those data from the CDC, we're talking about between 896 and 900 people out of 4 million births. It's a rare event. The thing we don't talk about, though, is the morbidity, because we think those are underestimated. The near misses, the Serena Williamses, the Beyoncés, right? The people who had some traumatic birth experience, some horrific thing happened to them. That's estimated at being 50,000 per year. And that's a grave underestimate, because that's just the ones we know about, right? So as we continue to think about how are we going to reimagine, how are we going to build a new care system that's really grounded in reproductive justice principles, we need to be thinking about not just who lives, but the quality of the birth experience, right? We are talking about a very sacred moment, the propagation of our human species. I'm a childless by choice person who's never been pregnant, but the truth of the matter is I have a deep amount of reverence for people who have the courage to want to parent, and we need to treat them as such. Right? The fact that we don't have paid family leave, the fact that we don't have extension of Medicaid benefits still in 12 states, right? That should be an outrage. And that we really should be using our professional organizations as well as our elective representative to shame those folks into doing what's right for the people that we serve. And I'm not a person who believes in stigma, shame, judgment, or blame, except when it's appropriately applied. And in this situation, if we're talking about the propagation of our species on this planet, then the people who are courageous enough to take that role on deserve not only the utmost respect, but every dignified support that they need in order to be able to be successful in doing that. And I don't care what your age is or what your situation or circumstance under which, said pregnancy occurred. I wrote this at the height of the pandemic. You see it's dated March 26th of 2020. I stand by every word. This was when New York City was shutting down accompaniment and locking out co-parents, grandparents, doulas, and a whole variety of other birth workers, and thought that pregnant, capable people should be birthing alone at the height of the pandemic. We were short personal protective equipment. And, you know, the ICUs and the emergency departments in New York City were being overrun and ravaged by COVID-19. And I still said that we should not be abandoning pregnant people, not in a city and a state where that Black women were 12 times more likely to die from pregnancy and childbirth complications, much higher than the CDC's recommendations at that time. I said we needed the collective will of the smartest people that we have in academia and clinical health services provision and public health to think about how we could do better by pregnant people. Because as a reminder, and I don't have to tell this audience, but I'm saying it for the recording, prior to COVID-19, pregnancy and childbirth were the #1 reasons why people were admitted to hospitals and healthcare institutions in the United States, right? I already said we had an estimate made it 4 million births prior to a pandemic. So we saw an intersection of a novel, you know, infectious disease agent and pregnant capable people bumping up against the #1 reason why people were hospitalized prior to COVID-19. And I really called for us to protect those folks, called for us to think differently about where we could be providing care, whether it was hotels. I called for devices and data plans. Let's send blood pressure cuffs and scales out to pregnant people. Let's deploy doulas who had already been in homes with people, already taking care of people, right? I stand by every word to this day. And people were mad at me when I published this and really stated that there was an ethical case to be made to reduce accompaniment for pregnant people during this pandemic. I stand by every word I wrote. I stand by every word I wrote in this. So when the bipartisan infrastructure bill got passed, which is not Build Back Better, Momnibus, paid family leave, postpartum coverage extension, all of that was tied up in the bills. And so one of the things that, you know, and my tweets always buy me some, you know, publication somewhere because a lot of journalists follow me on social media. And this is another piece that I want y'all to consider. If Nazis, bots, and trolls are the only people using social media and YouTube and LinkedIn and Facebook and Instagram, then why are we confused when the public is you know, subject to misinformation? If you have no social media account, I highly suggest that you get one, even if you're just going to be a lurker and you can amplify fact-based and evidence-based information. Okay. I am talking to everyone here. I am so grumpy about the fact that nursing was very clear about how not to use social media specific to HIPAA violations and all of that, but we never taught people how to use it. And now we're in a situation where misinformation runs rampant and we have no way to communicate public service announcements to the public. So if you can, if you will, please, even if you're not going to push out content or generate content, amplify at least evidence-based information or places where people can get it from. We are in the fight of our lives specific to making sure that the public can get to trustworthy sources. And I don't know any better way than to try and use the exact tools where people who are purveying this information are using it. A tweet got me this. I retweeted ACOG around postpartum Medicaid coverage and really talked about, you know, their lobbying efforts to try and move this forward, even though we can't have single payer, which is a whole other discussion. And the reason I point this out is I also wrote this with early career investigators, with colleagues, with collaborators, with Post-Dobbs. It's important that we raise up the next generation of nursing scholars, clinicians, public health scholars, clinicians, you know, educators who can talk directly to the public. And so in whatever role that you have, in whatever, you know, domain that you are working in, I'm trying to get media training for everybody, because misinformation is going to continue to get a lot of people killed unnecessarily. And our prevention strategies and efforts will not work if we don't have venues through which to talk directly to the public. And as long as our institutions are currently being discredited, We need places to directly talk to the public. Again, another tweet me got this piece that was led by postdocs and scholars and learners. Reproductive justice allows you to reject binaries, right? Abortion is not an either or conversation. We have data that shows it's way more complex than that, right? Both qualitative and quantitative data. We published our qualitative data in Women's Health Issues, and we published 2 quantitative papers, one in the Journal of Obstetrics, Gynecology, and Neonatal Nursing, the other in Women's Health Issues as well. This is way more complicated, right? Our early studies showed that when nurses said no to taking care of abortion-related patients, it wasn't because it had nothing to do with abortion. It had to do with the fact that they had no idea, they never had any educational exposure, so they didn't know how to translate their skill set. They had no idea how to, be prepared for the emotional trajectory that runs from elation and joy to frustration and sadness, right? People were trying to work through their complicated feelings about abortion in real time while still trying to care about pregnant, capable people. The other thing that came up is for a lot of people, we have these personal experiences ourselves. And for some of us, it triggers those experiences. It's way more complicated than people just say pro-life and pro-choice. Way more complicated. And nursing, we are so good at managing transitions. In public health, we are very good at nuanced conversation. So this acceptance, this blanket acceptance that this is an either or discussion, reproductive justice allows you to reject that because it is more complicated than we ever will capture in our scientific enterprise. And this is where I think the adaptation of the life and basic sciences falls short when you're trying to study complex phenomena like humans. And I say this as a basic science, molecularly trained oncology genomics person, right? If you are trying to study complex phenomena, you need complex theoretical and structural frameworks to help you understand how you're generating your research questions. And that's why reproductive justice is powerful. It is an advocacy tool. It is a strategy. It is a theory, and it is a praxis. It is all of those things. And so you can reject binaries if you're using reproductive justice as an operationalized framework in your research studies. You don't have to agree with the ways in which we currently conceptualize sexual and reproductive health. So we have a confluence right now of factors with unintended consequences, and that's why I think reproductive justice is so important and so necessary for our current conversations and decision making. I don't have to tell this audience that this is Katie Casamano. Many of you know her. She is a health services researcher at the University of Minnesota. I love her work. The closure of rural obstetric services, reproductive justice allows you to take that to a whole other level. It's not just the loss of those services and the health needs of rural populations. What happens to the workforce? Where does all that expertise go when you close a rural obstetric unit, right? What are the educational needs of the people in the emergency department if the hospital remains open, but the OB pieces? How we've always had OB triage, right? So are we training up the ED nurses so that they can fill that gap? What happens when that rural obstetric closure or that rural obstetric unit is a community resource, right? A lot of those places were providing community-based baby showers. Who's picking that up, right? Do we need to, bolster home visiting in the context of this so that we have a early warning system in the postpartum period, right? Reproductive justice allows you to ask all those questions, because you're not just thinking about the episode of pregnancy and birth or the place where that happens. You're thinking about the entire context because RJ affords you to do that. We think about abortion restrictions, and we waiting for Dobbs versus Mississippi right now, right? We just saw this weekend where a young woman had been reported by hospital and healthcare workers around her miscarriage, was put in jail and had to set a $500,000 bail. Really? Did anybody check on her mental health to see how she's doing after her miscarriage and her jail experience? That's what we're doing. That's who we are. I want us to really rethink how we are preparing for, let's say Roe does fall, and reproductive justice posits that Roe was never the best that we could get. right? Because it really wasn't. The word physician is in Roe more than the word woman is. So that was really about the decriminalization of abortion and protecting physicians. It really wasn't about a human rights approach to pregnant capable people to bodily autonomy. So as we think through, and I had a conversation with the American Hospital Association, what's the plan? How are we going to be prepared to take care of, the almost million pregnancies that otherwise would have ended in abortion, let's say if Roe was banned? How are we improving our care infrastructure when I already told you that our workplaces are inhumane? So can we reimagine that? But also, can we be retrofitting the services and the need? What are we asking of home visiting? How are we going to bolster? How are we going to think about hospital-based care? Right? What do the emergency department nurses need to know in order to be able to keep people safe? Or how are we thinking about the maternal morbidity and mortality crisis in the context of continuing pregnancies that otherwise might have ended in an abortion? How are we thinking about that? And where can we have those discussions? Reproductive justice allows you to talk about those things unapologetically, centering the people that we serve. I want us to keep our eye on this, because I really think if the crisis pregnancy centers and Title 10 and contraception, if they are going to continue to receive state and taxpayer dollars, I think we need to hold them to a better standard. And there are a lot of people who don't agree with me. They think that the crisis pregnancy centers, pregnancy help centers, they should be closed or they shouldn't be around. I think they're clearly serving a function and a need that people need. So how can we partner with them to get them to do better? Because if you're going to have MCH state tax dollars like they do in Indiana and like they do in Ohio, okay, so then what is their early warning detection system in the postpartum period to make sure we don't lose more pregnant capable people of the pregnancies that they're preventing, because that's their goal? I think we need greater measures of accountability and greater structures of accountability as we walk through this new landscape. And we need to raise our expectations of who's going to take care of what. Because if the crisis pregnancy centers are going to continue to operate without clinical services, then but extracting clinical service dollars or essential maternal child health dollars, then we need to connect the dots for people around where they can get care if it's not going to be at the crisis pregnancy center. That's our work. Reproductive justice posits that we need to center the people that we serve and that we need interventions and strategies toward health, right? I was horrified when ProPublica came out with this piece. And this is from 2020, August of 2020, where they saw that when Beyonce, so Serena Williams wrote her first person essay in Vogue after she had her baby in January. Beyonce wrote hers for the September Vogue that same year. And ProPublica did this looking, and Beyonce talked about toxemia of pregnancy. A lot of us call that preeclampsia, right? But when you went to go search for toxemia of pregnancy, there was so much inaccurate information or outdated information. The most current one, including at my current university's website, by the way, saying that, having the person birth or that delivery would resolve preeclampsia. We know that's not true, right? I mean, now we've had evidence and data to show that you can still have preeclampsia in postpartum period, right? So, but websites still said that the number one intervention for reducing preeclampsia was birth or delivery. Even my own university website. Now, our social media was more up to date. And so maybe at some point we need to think about using the websites that we have or information hubs that we have in partnership with social media, such that when evidence is changing rapidly, or when we are thinking about needing to push out fact-based information very rapidly to the public, maybe we will follow reproductive justice leaders and use social media differently than we use our legacy websites or our brochures or other materials that we create for the public. RJ is very good about pushing content out on social media channels, and maybe we need to take a lesson from them about how to be able to do that, or how to host tweet chats and to make sure, because I mean, the people we serve are using these platforms. So what better way for dissemination to be able to allow for that democratization of information? So let's see. If we got some near misses, we've got decreased access to information, we've got race as a risk factor, or racism as a risk factor, and we've got inaccurate information. So why do we care about any of this, right? Well, because we're going to have continuing pregnancies that would have been prevented or ended. And then all our efforts around reduction of maternal morbidity and mortality, I actually think our numbers are going to get worse. And I said this to the March of Dimes, and I said this to centering pregnancy, and I've said this to anybody and everybody, right? All the efforts, Merck from others, all the efforts, all the attention that we have put into reduction of maternal morbidity and mortality, especially around the preventable conditions, I think our efforts are not going to be reflected in our statistics. Because now we're going to have a health system that's already oversubscribed. I mean, reminder, there's like between 898,000 and 1 million abortions in the United States. Like, if those pregnancies are going to continue, I mean, the people who have births and the people who have abortions are not different populations of individuals. They're the same people, they just at different time points in their lives, right? A lot of people like to think about their different populations, but they actually really aren't. The Turn-Away study taught us that 88% of people who have abortions are already parents. So I am concerned that our efforts in improving, maternal mental health and improving maternal and reducing maternal morbidity and mortality, improving infant mental health. And I just think our efforts are going to look worse before they look better if we don't act. And reproductive justice is the way for us to be able to act. So let me apply the 3 R's of retrofit, reform, and reimagine. You've seen these slides already. I'm going to walk you through how we can apply it and really be thinking about the operationalization of reproductive justice. Well, if we were on retrofit the loss of obstetric rural services, we can reopen those units. That's a retrofit. It's not that difficult, right? We can either take COVID-19 money or omnibus, or we can just reopen those units. If we were going to reform, we could train other staff to pick up OB triage, including home visiting. We could expand nurse-family partnership. We could think about birth setting, right? And to really start to wonder what uncanny partnerships could we have, either with birth center, freestanding birth centers, or other kinds of auxiliary maternity units that we could develop. And we wanted to reimagine, we could build the necessary supports for birthing people, right? We could start from scratch while we're still doing the retrofits and the reform and really rethink all of this, right? I don't think that home monitoring should go away, whether it's for NSTs and up to the cloud and being able to have somebody look at that, to the, drive-through baby showers and all of those other pieces. There were certain telehealth, there were certain innovations that came about because of COVID-19 that should remain. And we have to figure out how to pay for those things. And we have to figure out how to staff those things. But reproductive justice would have us do all 3 of these things. But when we think about crisis pregnancy centers, okay, so the retrofit is we need greater accountability, and we can rebuild the Title X network, right? We can make, because there's standards for that. We can say crisis pregnancy centers, if you're going to receive Title X funds, well, then you need to meet the criteria of the network, right? We can do partnered services. Choices in Memphis, Tennessee does this really, really well. There's a crisis pregnancy center right across the street from their health center, and they are a midwifery-led, Black midwifery-led, comprehensive birth, abortion, family planning. They're managing a panel of 250 trans-identified individuals as well. They refer patients back and forth across the street, right? What are the partnered services that we need? What are the uncanny relationships? What are the asks that we need to have in a post-Roe landscape that historically we've never had to bring forward before, right? How are we thinking about our partnerships with religiously affiliated institutions and their discomfort with sexual and reproductive health? And how can we talk with them in a respectful way to center the people that we serve, to get them to understand they have a role to play in all of this, right? If we were going to reimagine, I think we need a workforce initiative. And I'm hoping all the current recipients, and I said this to Alexis McGill Johnson yesterday, the president of Planned Parenthood, all the people that's got Mackenzie Scott's millions, we need a consortium, we need an incubator and an accelerator around workforce initiatives that's really grounded in this notion that the people we serve are the most uncanny, untapped workforce that we have not looked at. And I know this is true. One of the first studies I did when I finished the PhD and started postdoc was to look at whether or not we could train formerly incarcerated individuals to become birth doulas. Why do we want to do that? Well, first of all, we already knew that 90% of people who have been incarcerated, at least Black people who have been incarcerated, are already parents or grandparents. So they already had some kind of birth experience that was personal, right? If you believe that experts by experience actually have capacity to be able to make good contributions, well, they could be trained as birth doulas. We also put in trauma informed care and harm reduction because we didn't want them to be re-traumatized going back into institutions like hospitals and jails. So we brought in consultants and people who had done this kind of work, like Erica Huggins from the Black Panther Party, who developed hatha yoga techniques for incarcerated persons for stress reduction and for cortisol preservation, right? What we found was not only could we train formerly incarcerated people to be birth doulas, but that meaningful work allowed them to advance their education. We had 16 formerly incarcerated low-income people. We had 3 people become midwives. We had 2 people finish baccalaureate degrees. None of them ever returned to jail or prison. We published these data in the Journal of Obstetrics, Gynecology, and Neonatal Nursing, as well as the International Journal of Prisoner Health. Those folks are still, they became a collective, the Roots of Labor Birth Collective. And they started as an incubated, fiscally sponsored organization within my university. Now they have their own nonprofit status and their own executive director, right? We can incubate these innovative models and these innovative products. Why did they develop themselves as a collective? Because they wanted to be able to take care of each other's children when they were at the births of others, right? To me, when I heard that, I almost started crying because that reminded me that similar to nursing, doula work is shared. Right? So how can we create models that really respect that sharing, right? Remember all the mutual aid we saw at the height of the pandemic? How can we really catalyze that as the next way of thinking about the work that we need to be able to do? So as, you know, all the McKinsey Scott, you know, reps, because I mean, she dropped what, $3 billion on reproductive health rights and justice last week, as they start to think about conceptualizing their work, I want to see the infant mental health community come together and say, you know what, we've incubated really innovative projects over time for a really long time. Can we be your partner in technical assistance to understand how to get people the community-centered care that they need, right? That's the kind of thinking I'm involved in. You saw this slide already, right? If we were going to retrofit this, safety bundles, let's do some implicit bias training. Because regardless of race or ethnicity, 1 in 6 people reported mistreatment. So clearly we need to retrofit something. But then the reform, I want our professional organizations to create space for us to do simulation, either with virtual reality or in real time. I want us to start disrupting some of these disrespectful interactions and doing it with love and curiosity. We need safe spaces to do that without legal threat and folks getting fired or canceled on social media. Like if our professional organizations took this seriously, they would elicit panels where people could practice this kind of stuff, right? Disruption, upstanding, bystander, right? We would have some innovative, fun workshops where we could simulate these things, right? That's what I'm going to do as the journal editor at Health Equity. I mean, I'm just saying, we're going to create a space where folks can practice with curiosity and love, not with judgment and blame. And oh, it drives me up a tree. Reimagining this would mean community oversight and accountability. I think every hospital, every healthcare institution, not only should have a community advisory board, they should have a community decision board. We could have a rapid response team where people could actually be deployed to come disrupt these interactions, because we care so much about our unit culture that we are paying community members to help us resolve these issues, right? I'm one person, these are my ideas. If we crowdsource a ton of great ideas about how to resolve all of this, I think we can make everything different, right? These are just suggestions to get your ideas flowing. For near misses, clearly we need to listen to and center patient voices. I can't believe almost 4 years after her, birth and her event, Serena Williams again had to pen another essay around what happened to her in Elle magazine. I'm glad she did it. And I'm glad her husband is going to start focusing in on Black maternal health. But the truth of the matter, that's a retrofit. A reform, again, would be to create some simulations and to provide people opportunities to practice. We've had team-based patient safety initiatives, for a very long time, and maybe we need to operationalize those in a more concrete way. And for Reimagine, we need a new workforce initiative, right? I mean, yes, we need to pay attention to the current workforce. Don't get me wrong, but we need to make sure that as we are developing our future workforce, that they are really embedded in the principles and the practices that we want to see, define the culture of our future units and the culture of academia and the culture that we want in policy. And we're not teaching them those skills right now in our programs. right? Talked a little bit about this. I still do not understand why we don't have fact-based information for 15 minutes every Friday in somebody's Instagram live. I don't understand why somebody from the Department of Health and Human Services, I'm gonna say this tomorrow when the vice president makes her announcement, somebody needs to be talking directly to the public, not just on the Sunday news shows. We need to say, hey, this is what the Omicron variant looked like. This is Delta Cron. This is what a spike protein is. Here's why we're worried about it. We have viruses mutate all the time. Like just 15 minutes. Like we could do public. Like we need science literacy in the ways in which, as a competency, you know, we always talk about scientific, you know, dissemination and highly ranked peer-reviewed journals. We need some infographics for the public. We need some like bullet points that will allow us to translate our very complex scientific finding. I mean, the taxpayers pay for our science, right? For those people who worship at the NIH, PCORI, you know, National Science Foundation, Troth. If they're paying for this science, then they deserve to understand it. And it's our job to translate it. So, right, science communication is huge. Necessary reproductive justice teaches us that. Why? Because we don't make a distinction between the science that we generate as researchers and the experts by experiences contributions to science. Right? I get really, really frustrated when I see people have community members and doulas and other folks come in as guest lecturers to your class. I was like, well, but did they get a certificate showing that they did that, or like to affirm their expertise? Like, there are all these things that we need to be thinking about, the structures and how we can utilize them differently towards a more equitable appreciation for the work that we do. The other thing I was remiss in mentioning, when I say reproductive justice, I don't just mean, you know, organs that allow us to propagate our species. I'm talking about the reproduction of ideas. I am talking about the reproduction of knowledge. I'm not just talking about ovaries and uteruses and penises and all of that kind of stuff. To me, reproductive justice is a play on words. It is a theory and a praxis, but the more I engage in RJ, it allows me to link the dots to a lot of different constructs that I think a lot of people miss. Like voting rights are a reproductive justice issue. Monica, why are voting rights a reproductive justice issue? Well, if the bulk of biomedical research in the United States comes from congressional allocations of funds to the National Institutes of Health and PCORI and the National Science Foundation, then who gets to make the decision about how those human money and space and time resources are allocated matters. So for me, it's very clear why voting rights are a reproductive justice issue, because how those resources get allocated downstream are being decided by people who don't believe in human rights, right? So as we think through our philosophical orientation to our work, whether it's policy or education or practice or you know, research, we want to be thinking about how we think about our work. And reproductive justice can assist us in understanding how to think differently about our work. So let's reimagine what's possible, right? I mean, I've just given you a couple of examples, but there are way smarter people than me who I'm lucky enough to get to think with out loud to try and like reimagine what's possible. If you don't know this document, it came out July of 2019. It was updated when the Biden-Harris administration came in. We don't have to rethink this, right? I mean, this comes from in our New Voices for RJ. There's a whole blueprint around how we get here, right? And there's nothing that I've said that's not in this document. We need to level up our expectations. You know, a lot of people don't know this, but I spent most of last December of 2020 interviewing with the Biden and Harris team because we were trying to really bring sexual and reproductive health and well-being to the White House in a new office. And part of that work of wanting to really move the federal levers, right? Philanthropy figured this out after the murder of George Floyd and Breonna Taylor and Ahmaud Arbery, and that we needed to do things really differently. But the levers of the federal government had yet to be shifted to really move away from this sort of very disease-focused way we think about sexual and reproductive health, but to really move more towards a well-being approach, move more to a health equity approach. And so we put forward, a revised blueprint to the administration to say, everybody wants to look at racism and how it shows up, and structural racism, and fund Black scientists, and the FIRST initiative and the Unite initiative and all these other initiatives. But what we really need is a blueprint of how to get there. And so I'm gonna make sure that the URL is added to these slides. You should read this blueprint. 90 different organizations signed on to it to really be able to say what the expectations should be of health services provision and human services provision around how we remake all of this different. And it has distinct priorities for public health departments, for clinical health service providers, for researchers, for policymakers, for funders. It is a very comprehensive report. But there's 10 things we could do right now. And I want to push us to think boldly about them. Number one, we need paid family leave. That's just a given. And I know it's languishing in Build Back Better, and they haven't, the votes. I mean, we may hear some good news about this later on this week, but baseline, people need to be paid to stay home, to socialize, to breastfeed, to manage the family transition. I mean, being a parent is like a huge thing. It changes your relationship with your partner, with your own parents. Like this, we need to own that for what it is. I think we need a basic minimum income, because I am very worried that we are becoming a country where poor people are unable to parent with dignity. And I find that to be completely unacceptable as a childless by choice person. And I want y'all to tax me as much as you need to in order to make sure that people who want that experience, that existential experience of being a parent, have a right to do so. This immigration situation we got going on, I mean, in this carceral system, I mean, again, we have to stop incarcerating pregnant people. I think we should stop incarcerating most people, but pregnant people in particular, because I think it's unethical to have babies begin their lives in jail. They are innocent citizens, right? But just because your parents may or may not have committed a crime. So if we're gonna move all the way to fetal personhood, then that also means that we need to protect innocent people from incarceration because they happen to be in utero, right? Again, reproductive justice gives you language to talk about this. That we still have gaps in maternal coverage, I think is shameful. And that we don't have fully funded Title X is a real problem. I mean, Richard Nixon signed that program into law in 1970 when, George H.W. Bush was, on the board of Planned Parenthood. Republicans have not always looked the way that they currently look. And so to forget that history, I think is also problematic. I think that we can have a dialogue about the need for abortion, not only as a tenet of reproductive justice, but we need to talk about its quality and safety. And we need to talk about it as a social good that a lot of people benefit from. I think we need to have everybody expand Medicaid. That just to me is just low-hanging fruit that we need to stop politicizing and just saying we're going to allow for poor people to have a full range of insurance benefits that employer-sponsor, benefits have. I think that all Black and brown birthing people need a doula until we can fix our labor and birthing units. And we have to stop thinking that doulas are going to fix a problem that they didn't create, but they are an essential member of the team and components of the solutions, and we need them. We need to operationalize the midwifery model of care. I currently am very excited to be serving on an advisory committee where historically Black colleges and universities, 10 of whom who've received McKinsey Scott money, are looking at developing MCH and midwifery programs. We've been meeting every other Friday since January, and we're looking to be partnering with schools of nursing as well as departments of public health and schools of medicine who are employing midwives to really create a new workforce development initiative with those philanthropic dollars. I'm super excited about that. And I need us all to believe that the people that we serve are the best shot at our future workforce, right? They've had interactions with our systems, they've engaged with us, they understand their own experiences. That we need to really start to think about the people that we serve as our future workforce and build pathways and pipelines for them to be able to become members of the health professions. I always say that if we were going to do healthcare reparations, we should ensure for 20 years that anybody who has received healthcare services at our institutions have a direct debt-free path to become members of the health profession in whatever way they want to be. If they want to be a medical assistant, a radiology tech, a nurse, a physician, whatever they want to be, healthcare reparations would allow for the people in the community where our institutions are to have a debt-free path to become members, and then they would become our employees. So I think we need to unleash the creativity. We need to use reproductive justice as the way to be able to do that. My closing thoughts are this: retrofit, reform, reimagine can help us break down complex contributors to health inequities and allow us to target our human money, and space, resources, and time. I think we need to start to think about distributing resources based on need, not on history, not on tradition, but really start to think about that distribution. We need a divide and success approach, and both reproductive justice and retrofit, reform, and reimagine allow us to do that, right? We don't all have to be on the reimagine team. Some of us are really good at retrofitting. I know I am. I would prefer to be on team reimagine, but I'm actually really good at retrofitting. And we need to figure out where we are on that circle so that at different time points, we can operationalize different roles. I think we need clearer articulation and communication. And if it isn't obvious to you, the need for community engagement, community accountability, community leadership is necessary at all components in order for us to really think about healthcare reparations and how we might all get to that future we reimagine that we want to live in. So with that, I'm happy for questions, comments, suggestions, and don't forget to dream. I think we spend so much time responding to our inhumane workplaces that we never have any spaces to dream. And I would like for us to do that, because the power of this group, the power of the people who have been involved and participating in this conversation, I think collectively, we actually really could come up with some really innovative solutions and strategies to really think about how we are going to navigate our current uncertain times, and how we are going to stand with the people that we serve. So I'm gonna stop sharing my screen and see what we got.